What's up, Z-Pack? It's your boy Z-Dog MD, aka Dr. Zubin Damania. I have a very special guest today, Dr. Dave Ramsingh, who is Associate Professor of Anesthesiology at Loma Linda University Medical Center, as well as Director of Perioperative Ultrasound there. Perioperative ultrasound,
Yeah.
What is that? And that's what we're talking about today. Dr. Dave, thanks for coming, brother.
Oh, thanks so much.
Yeah. So you brought hella gear.
Yep.
You
that's
brought
what I do. Yep.
a naked man into my facility who is anatomically incorrect. Mannequin. Okay. As long as because I was feeling uncomfortable.
Yeah.
All right.
But
as long as we're on the same page. So what? Tell me about this perioperative. So ultrasound has been a thing forever and ever.
Yep.
The big, huge devices in the OB suite,
Right.
in radiology,
Right.
the RadTech sonographers come up and do the thing. You wait for the radiologist to read it. It's a lot of times inconvenient because
time
stuff's-
delays, the patient's changing, acute events happen. Yeah.
all that stuff.
Right.
But then in the emergency department, homies have been using a kind of a portable ultrasound for a while
Right.
to do all kinds of damage.
Right.
Misdiagnose tons of things, cause terrible clinical decisions to be made, but also put in lines, make sure there aren't pleural effusions,
Right.
do other clinical...
Done a lot of good too. Right.
Yeah, tons of good.
Yeah.
But it hasn't really filtered to the perioperative space, so around surgery, anesthesia. Why is that?
You know, that's a great question. That's something that I've been passionate about for about the last 10 years or so, about really trying to incorporate ultrasound into perioperative care, into bedside care, very similar to how emergency medicine and critical care is using it. The same way, the acute events happen in the hospital in a variety of settings, right? We all know that patients in the ED can be short of breath, have chest pain. Well, those events can happen in the perioperative space too. They do happen, right? I am encountering those on a fairly frequent basis.
So at that point, you pull out your stethoscope,
Right,
someone's short
exactly,
of breath, they're
right.
desatting, the blood pressure's dropping.
Yeah.
So you pull out your stethoscope, which is 200 years old.
Exactly. 200 years old technology, put it on the patient, pretend that I know how to use it or really interpret how any of us really know how to use it, right? And the reality is I think we need to address that. We need to be aware of what that technology is, the limitations of it, and look and explore what other things in innovation have allowed us to use to replace it, perhaps.
Well, it's interesting that you say pretend how to use it, because I think the stethoscope is a badge of sort of pomp and circumstance, healthcare, and it's a laying of hands, and that's all great.
Right.
But if you actually go into, okay, can I diagnose the murmur?
Right.
Can I figure out if there's a pleural effusion? Is there fluid in the abdomen? What's going on? Did I just cause a pneumothorax? Is the ET tube, the endotracheal tube, in the right place?
Exactly, yes. All those questions, right? That using a stethoscope research has shown that is not very accurate, right? It's essentially a flip of a coin in most of those situations of actually becoming to a better diagnosis than you just going with your gut, right? And so I think one of the coin things we talked about for the perioperative area is getting out of the guessing game. We talk about the fact that using ultrasound helps us come to the diagnosis faster, more accurately, and get those therapies to the patient in a much more prompt and rapid manner.
So Dr. Dave, first of all, just dive in. Teach us what is this portable ultrasound thing?
Well, yeah. So I mean, ultrasound now, right? And in our minds, ultrasound is still kind of viewed by a lot of folks as this kind of cumbersome, big device that you have to get a specialist to come into the room, takes up half the room to go in and do. The reality is that these things are changing, right? There's laptop systems that are available. There's ones that actually plug into your phone that you can give you full imaging. And so just to show you quick things you can do to evaluate patients, there are exams that you can do to place the probe just how you place your stethoscope to look at the heart, for example. So we'll talk about this view here, placing it right to the sternum. Just remember, if we talk about how we would look for things like aortic stenosis, right? You're trying to look for the idea of feeling that third or fourth rib space, and you're trying to look for that loud, holy systolic murmur. Is holy systolic murmur?
I call it holy systolic because it's like a holy event when you hear it.
Right, exactly.
Because we're pretty much faking it.
It's totally faking, right?
The stethoscope,
Exactly. So now let's talk about how we can put ultrasound in a very similar position, and now we're able to get a view of the heart, right? So there's the cross-section of the heart right there.
At that. Wow.
Left ventricle, we can see that it's squeezing right there. Yeah, that circle right there, exactly. And then the right ventricle right outside. And I'm just going to flip this probe around the other direction and show you that in the long axis, right? And so now we're able to see whole left ventricle right there. And there's the mitral valve and left atrium, right? And
mitral valve,
right. And just getting that piece of information, is the heart squeezing or not, right? We can look at that valve. There's the mitral valve right there. And you can see just on a 2D picture that it's opening up, right? There's a big space between that. That is how potentially point-of-care ultrasound could be useful right there, exactly, yeah. So it's just opening up nicely. We can see that. If we put in the aortic valve here, we can kind of just slide up our probe to be able to see more. There's the aortic valve right there. And we can see, You can see that opening up very nicely. This is, again, how point-of-care ultrasound is a useful technique. So rather than just trying to pretend via our stethoscope that, oh, okay, I think I hear, I don't hear, we can use ultrasound, sound waves, to produce an image to see pathology potentially at that bedside setting, rather than just sort of guessing with our stethoscope.
Oh, I love this so much. I love this so much. Can I go back to the screen real quick for the muggles? Okay, this is amazing. Let's get a full aortic. Yeah. Okay, blood comes in, okay, to the left atrium here from the lungs.
That's right.
Goes into the left ventricle, and this muscle squeezes it out, this aortic valve, into the aorta, the biggest artery in the body. And this is the flow of blood. And you can see it with these bounce sound waves like what a bat would use. It's absolutely tremendous. What is even more tremendous is the fact that you can teach us how to do this on an inanimate object with software that fakes it.
Right, yeah, and that's, technology, again, it's really the advancement of technology, just like with our smartphones now, you can do so much with these things. Medical technology is also coming the same way, right? But the problem is education, giving awareness to different providers about what exists and how to learn about it, I think really is some of the roadblocks that we're facing nowadays.
Well, this is the thing. So your passion is educating people about ultrasound. You teach a course, conference that brings people together to learn about it, especially for perioperative space, which is not classic. Breaking down these silos of education where, the ER guys are doing it, the radiologists are obviously doing it, the ICU guys are doing it. Right. Why would it not work for people in the OR when people are sick and so on?
Exactly, and you hit the nail on the head in the sense that when people are sick, right, so hospitalists, internal medicine, family practice, if you're dealing with any situation where you're going to the bedside because the patient is ill and you have a question that you need to address, we can talk about how ultrasound could be helpful to improve your ability to assess that patient. Perioperative is the exact same thing.
And the teaching part of this, so being able to teach residents, because when I was a resident, we had to go to the body, and even then, they didn't have this portable stuff.
Right.
It was tricky, so to put in lines, we had to use the force, to hope we didn't drop a lung, all those other things. Now you can show me on Humberto.
Yeah, that's right. Humberto, okay.
Humberto, because we're all inclusive here at ZDogg Industries. We want to make sure we have a good ethnic profile. Logan is Scottish. Tom is as white gets. You and I are Indian. So we need Humberto. Humberto can teach us a lot. Now, this particular device, is this what you use in your conference as well?
Yeah, so we have a lot of technology at our conference to be able to kind of, to your point about how we can educate different levels of providers on how to use this. We have simulation, we have true ultrasound device, we have real models that we invite to come and let all our attendees practice. They get over 6 hours of hands-on, because that's the key to this, right? Yeah. Just how you're learning how to use your stethoscope, you have to practice. You have to place it on the patient and assess that. And so same thing with ultrasound.
Yeah, and this is really a way to augment the stethoscope, which is an ancient ritual type
200
thing.
years old.
200 years old, intuition-based, using the force. It's kind of like a lightsaber. Like, it only works if you have force powers.
Yeah. Right.
And my force powers are weak.
Yeah, mine are too, and I don't know how, rather than spend another 15 years honing that in, right, why don't we just use some new technology to try to get there a little bit quicker?
Cheating, you are, Dr. Dave.
Well,
a cheater!
If it lets you do the right thing for the patient, right?
That's what it's really about. It's about Humberto.
That's right.
It's about actually making sure at the point of care you make decisions quickly. You're not foregoing regular formal scans. You're just saying, look, they're not here right now. It's post-op. He stopped, he's short of breath, he's desaturating, his blood pressure's dropping. What's going on? I can look at the heart, I can look at the lungs, I can look
at
Yeah,
and that's exactly it, right? Those acute events happen in the moment. How are we going to be able to assess that patient and to the best of our ability?
But you noticed in anesthesia, because ER was using it, ICU was using it, point of care ultrasound, or POCUS.
Right.
They were using this stuff, but in anesthesia it wasn't really a thing, and yet you're seeing all this acute stuff. What's the holdup? Why is everything so siloed off?
Well, I think there's a lot of ways you can look at this in the sense of how we're brought up in our specialty training, right? We all go to medical school, we learn the basics of anatomy and physiology, and then we go down our specialty line, and then we really kind of judge ourselves and train ourselves by our own peers, right? So, my sort of reward system is based on going to conferences of my own specialty, doing research in my own specialty, and we kind of just support each other and don't really break out into other specialties and see what else has happened. And so I think that's what's happened with point of care. It's been developed in these other acute care specialties, but because there's not a great way of communicating, right? There's not a great network of sharing sharing information across different specialties. That's, I think, one of the reasons why there's been a delay in the adoption. But again, if you go back to the patient, right, those events happen to the patient throughout the continuum of someone's hospital stay. These patients, again, are having short of breath, hypotensive, all these different, full stomach, inappropriate tube position. I can go over situation after situation that are relevant for the ED space, the ICU space, and for the OR perioperative space as well. And so now we're trying to bring that back. And there's a group of us now for the past 5 years that have really tried to bring it into the perioperative space now. But yeah, the silos of medical education and technology development is an issue that we need to kind of really approach.
So come on in here, because one of the things I think that, and these nipples are hypnotic to me. One of the things I think that really interested me when you reached out about the work you're doing is that you are in the process of breaking these silos down. You're saying, you know what, we're going to create a training protocol for anesthesiologists to use point of care ultrasound in the perioperative setting to help the surgeons and help the whole team figure out what's acutely going on with that patient, instead of throwing a stethoscope on and effectively intuiting or guessing based on sound waves and subjective interpretation. Instead, we're going to use sound waves and subjective interpretation in a more objective way.
That's the
with
perfect
ultrasound.
Yes.
Can you describe kind of in a perioperative space? We have a lot of fans who are perioperative nurses, doctors, etc. What are the sort of things you can look at with point of care ultrasound, which, by the way, is just a probe on the skin with some gel?
Exactly. I think, well, first to talk about the point you just said about really kind of addressing point of care ultrasound as its own entity, right? People, I think, a lot of time talk about ultrasound imaging as historically as it's been classified, a big machine required by a specialist to come in and interpret it. Point of care ultrasound is not that. Point of care ultrasound is the idea of just how you use your stethoscope at the bedside to help in those acute situations. Well, we're just talking about using another piece of technology, ultrasound, to put it on the patient at the bedside and come up with more information. So I think labeling it as something different is the key thing, and that truly is point of care.
So it's interesting because when you think about disruptive technologies, disruptive technology means you take a technology that normally was relegated to big, huge machines, expensive and high quality, with gatekeepers like radiologists, and you make them smaller, more convenient, less expensive, usually of lower quality. So in other words, your read of an ultrasound is never going to be necessarily as good as a formal radiologist read, but it's right there at the point of care, helping you make a decision the way your stethoscope would. And that's the difference, because my wife gets really upset about when like ER docs want to use an ultrasound and make these high-level diagnoses like gallbladder stones, cholecystitis. It's very hard to do that accurately without lots of training. Now, with the amount of training they get, you can do a lot of things using it as a replacement or an adjunct for your stethoscope.
Exactly. Adjunct is a perfect word for it. And you speak a lot about this, about the scope of practice and us all being aware to that, right? And I think that's a key part with ultrasound is we have to keep it within our scope of practice. But if you again go back to the situation of these events are happening, right? And we're just trying to arm our tool belt to assess the patient and prepare for the management of the patient to the best of our ability, right? And ultrasound definitely has a place in that realm. Perfect example, I shouldn't be using ultrasound to look at septic joints because that's not in my scope of practice, right? And so, but if somebody is short of breath or complaining of chest pain or their blood pressure is tanking immediately after surgery, there are techniques with ultrasound that I can implement that will get me to a diagnosis a lot faster when I don't have any other ability, there's no consultation, there's no ability to get that at the point of care, at the bedside, right? Using ultrasound to really kind of address those questions and come to the diagnosis faster is where its utility lies.
So, Dr. Dave, blood pressure's dropping perioperative, it's a cardiac case, there's not great heart sounds on the stethoscope, you're wondering what's going on. What could the ultrasound show us?
Yeah, sure. So let's just do that example right now. So quickly come
Hang in there, Humberto. Don't you die on me, Humberto. Don't you die.
So first, try to wait for the situation.
Get the CPR out of the way.
Okay, great. Yeah. And then now, so let's talk about it. We have that patient who's crumpling right in front of you. You don't know, is it the heart, the lungs, what's going on? Quickly placing the probe in a position that, again, with training, you learn to go with right off the bat. We have a picture of the heart here. And look, this is very different from the picture we had before. There's a lot of fluid
with this
all around.
So for the muggles, this is the pericardium. It's the area or the sac that holds the heart, and it's not supposed to have this much stuff in it.
Right, exactly.
So what is that called?
So those patients undergoing a tamponade because they have a large, rapid collection of fluid there in the pericardium. This large pericardial effusion is actually impinging the ability of blood flow to fill the heart. And
the whole thing is squeezed and unable to fill,
Right.
and therefore you can't get stuff out. And this is a medical emergency that you have to treat right away.
Exactly, yeah.
Yeah.
Otherwise, you will lose this patient. And
Yes.
this is something that is common in any acute situation. You will come across this from time to time.
Don't you die on me, Humberto. I just met you, and I'm starting to get used to the lack of genitals and the strangely correct nipples.
Nipples,
So, again, tamponade, a great example of life-saving stuff. By the way, when we were in medical school, the way we remembered tamponade is we would think of it like, we always pronounced it tamponade, and we would remember like Kool-Aid. And there was this commercial where the Kool-Aid guy would break through the wall. Right.
Yeah, yeah.
So we'd be like, hey, and it was like, his blood pressure's dropping and his pulses are weak. What's going on? He just had cardiac surgery. Hey, tamponade. And he would come to this big old heart. Oh, yeah. That's how we remembered it. It has no relevance to anybody other than us, but I just told that
I
story.
remember that. And
You
that's
see?
yeah.
Don't you
Yeah.
die on me, Humberto. How are you bringing this to the world in terms of educating people, especially in the perioperative space where it's not commonly used?
Yeah, so I've taken on the initiative of through my department at Loma Linda University and affiliation with UCLA Medical Center we have a workshop that we teach every year on trying to advocate for any acute care specialist, but particularly focus on perioperative, for them to come and learn on point-of-care ultrasound. We have a head-to-toe examination we've coined for the Foresight exam. I have a website that I've put all our content and podcast on that. Again, it's copyright free, it's open source to anybody
Open source.
to access, look at, download, use it however they find useful to them to kind of get some knowledge on the
It's a
topic.
free open access medical education, or FOAMED.
That's right.
And the conference, and we'll put all the links to everything that Dr. Dave is doing, including this conference, which I think is going to be awesome. If I were in the perioperative space, I'd probably go there. Unfortunately, I'm not. I'm in the medical parity space, which apparently doesn't use ultrasound.
I could use ultrasound too.
You know, there's lots to scan. Speaking of medical parity scans, I think there's somebody in this very room who could use a scan of a lot of things because there's so much wrong with them. I'm thinking Tom Heineber. What do you think, Tom Heineber?
Let's do this.
Are we going to scan taint, testicles? What are we doing?
No.
None of that.
Okay. Well, that's unfortunate.
Well, that makes it really less interesting,
Yeah.
doesn't it? But let's go ahead and do something like heart.
Yeah, let's go quickly. Yeah, let's take a quick look.
So there's the goo.
Gel,
Now,
right?
what's the
So
purpose of the gel, man?
So the gel allows, just like sound waves, right? For you to be able to just think of like headphones, for it to get into your ear, you have to have the ability of allowing those sound waves to go into the body. Gel allows that to penetrate through the skin because there's no air interface, right?
Got it.
The whole
Gotcha.
problem is the air interface that prevents ultrasound to penetrate.
Cool.
Got it.
All right. So,
All right, what are we going to scan?
I don't know.
all right. Well,
tell me.
we'll take
Just
a quick-
start flexing because it's going to get real.
I need to take off my shirt?
Yeah.
There's no time. There's no time, guys.
Oh!
Let's do this.
Oh!
Let's do this.
Normally, I don't recommend that for our face. That's not a good way to start off the exam, just ripping off the shirt. But sure, we can do that.
You know,
Zach.
I've seen many things in my life, but I've never seen the incredulous
Hulk Hogan,
Hulk.
that's right.
Yeah, I mean, he is a real American. But look at those pecs.
Glad I did push ups.
Can you scan through that much muscle?
We'll find out. We'll find out. I have to crank up the power here to see if we can.
All right, I'm ready
All
to
right.
scan.
All right,
do
let's
this.
take a look. So we're just going to place probe right here, sort of top of your belly right here, in the subxiphoid space. So, the neat thing about a lot of things with point of care is that it allows us to kind of do quick stratifications, right? Good heart, bad heart kind of things. And so one of the things, you see the left atrium sort of the bottom of the right of the image there. Bottom, keep going, moving your finger down right there, yeah. So that's the left atrium. And see how it looks very similar to the size of the aorta that you were pointing up right above it there with the valve? That is a quick way to say, to show that the diameter is roughly the same. In heart failure, the first thing that you do when you get into more of the severe stages is your atrium starts to dilate. So from a point of care side of things, one of the quick things we can do is look at that size and compare it to the aorta. If it's twice the size of the aorta, we know our patient has potentially some heart failure, and then we can do further diagnosis, further ultrasound to evaluate what the mechanisms of that heart failure is. But a quick stratifier, this is just one example of how point of care ultrasound, good heart, bad heart. The
Right
atrial
away,
size.
real
Yeah.
quick.
Yep.
And here's your aortic valve, yeah?
Right there, yep, there's the
So
aortic
you
valve.
can see if there's
Opening up.
massive flailing.
Exactly, yep, opening up. We can put color here and see. Not the best view to look at color of the valves, but we can still put it here and just look to see if there's any sort of quick way. Do you want to know if you have any?
Yeah.
All right, so we can.
We're going to find out right now.
What do I got going on?
Tom's life insurance
Is my
plans.
ticker broken, Doc?
Well, let's just say, you seen the Tin Man?
Yes.
Yeah, that.
No, but you're putting color flow, getting an idea of how the valves are opening and closing, seeing if there's any severe pathology. Again, with the idea of just quick point of care, is there acute issues that potentially could cause, at that moment, decompensation?
Right.
Dude, how viral would this be if I just had a heart attack like right now?
It would be amazing. You would see the
We'll
stunned,
be able to tell right
stunned
now. We can look at
myocardium.
that,
Yeah.
So right there, there's sort of that circle that you see. That's the left ventricle in cross section. So we're just looking to see how much it expands and contracts as a gross assessment of function, right? Is it moving? Is it squeezing well or not? And in the point of care, if your patient is having an MI, grossly hypotensive, it's not subtle, right? It's looking to see gross decompensation in the heart failure situation is very, very quick to pick up.
Right, so you're not looking for these subtleties that you trained for years as a radiologist to pick
Right,
up. You're
right.
looking for, it's not
Yeah.
moving much.
Heart doing
Yeah,
this
doing that.
versus this.
Yeah.
Exactly.
Yeah.
Right.
And his seems to be squeezing reasonably well
yeah.
for someone who's a meth addict, a crack addict,
That's true.
and a chronic user.
It's not addiction if you enjoy it.
That's
Yeah.
been discussed.
Right.
Yeah.
There's so many applications. Again, point of care is really meant for.
I love it. It's very hard to have a serious clinical discussion with Goober McPatagonia over here. Show the ladies. This is just for the ladies now. Thank you, Tom Heineber. So times are changing so much. It's exciting to see.
Yes,
And it's exciting
yeah.
to see young doctors like yourself in academic institutions pushing this change. So many medical students and residents, when I round with them, they're like, I don't do the physical exam anymore. We don't have time. We're too busy clicking boxes. It doesn't work. I'm not good at it.
Right.
No one trains me in it. But this ultrasound is actually bringing us back to the bedside.
Exactly.
It's actually laying hands on the patient. It's having you, an anesthesiologist, going and talking to the patient, putting the gel on,
Right. Yeah.
doing the probe.
It makes it relevant again, right?
Yeah.
It makes us the need to go back to our patients and assess them because now we have useful information that we can glean from them that actually will help alter and affect our management decisions is coming more of age because, again, this is the next stethoscope.
Dave Ramsing, I'm so excited to have you on the show. I'm so glad you came down from Loma Linda. You have the conference, which we're going to link to, where people can train in perioperative ultrasound.
right.
You have the websites with all this free, just wealth of knowledge. Your goal is to bring it to the world and to transform the perioperative space, which I think is absolutely as Health 3.0 as we can get. Dr. Dave, thank you.
Thank you so much.
Thanks,
Pleasure.
brother. Really appreciate it. We out!